Hello, and welcome to the Cardiology Podcast, Why We Do What We Do in Cardiology. In this audio series, we will discuss the practice-changing articles in cardiology from the past to the present. This is your episode for today.
In this episode, I will discuss the 2023 European Society of Cardiology Guidelines for managing infective endocarditis. This guideline was published in the European Heart Journal on August 25, 2023. The new guidelines for diagnosing and managing infective endocarditis were developed to reflect the latest advances in the care of patients with this disease. The previous guidelines were published in 2015, and since then, there have been significant developments, including 1. Refinements of the indications for antibiotic prophylaxis. For example, it's now a Class 1 indication to use antibiotic prophylaxis in patients with ventricular assist devices. In patients with heart transplants, it's now a Class 2B indication to use antibiotic prophylaxis. 2. Improvements in diagnostic capabilities. Echocardiography remains the first-line imaging modality for diagnosing endocarditis, but CT angiography, MRI, and nuclear imaging can also be used. 3. Establishment of endocarditis teams and heart valve centers. Diagnosing and managing patients with complicated endocarditis should be done early in a heart valve center with surgical capabilities and an endocarditis team. 4. Identification of patients eligible for outpatient antibiotic therapy. For example, patients with IE can be switched to oral antibiotics once they have reached a state of clinical stability. 5. Diagnosis and risk stratification of patients with complications of endocarditis, in particular, stroke. 6. Management of patients with transcatheter heart valve and cardiac implantable electronic device associated endocarditis. 7. Patient-centered care during the acute and follow-up phases of endocarditis. For a busy clinician or cardiologist, the following are the key points to remember. Prevention. Populations at high risk of infective endocarditis include 1. Patients with previous infective endocarditis. 2. Patients with a surgically implanted valve, transcatheter valve, or prior valve repair. 3. Patients with uncorrected cyanotic congenital heart disease, or CHD, or those with congenital heart disease and last repair involving prosthetic material. 4. Patients with a ventricular assist device. Patients at risk of infective endocarditis should follow general prevention measures, such as brushing their teeth twice a day and seeing a dentist for professional cleaning and follow-up at least twice a year for high-risk patients and once a year for others. Practicing good skin hygiene, including treating any chronic skin conditions, cleaning and disinfecting wounds, taking antibiotics to cure any bacterial infections, not self-medicating with antibiotics, following strict infection control measures for any procedure that could put them at risk of IE, avoiding piercing and tattooing, limiting the use of infusion catheters and invasive procedures as much as possible, following strict care bundles for central and peripheral cannulae. Antibiotic prophylaxis is recommended in patients at high risk of infective endocarditis undergoing an oral dental procedure. Antibiotic prophylaxis should be considered in patients with prior transcatheter mitral or tricuspid valve repair. It may be regarded in heart transplant recipients and among high-risk patients undergoing invasive respiratory, gastrointestinal, genitourinary tract, skin, or musculoskeletal procedures. Antibiotic prophylaxis before dental procedures is not warranted to prevent cardiac implanted electronic device-associated infective endocarditis. Patients with an intermediate risk of infective endocarditis have a higher risk of developing the disease than the general population, but not as high as those at high risk. These patients include those with rheumatic heart disease, non-rheumatic degenerative valve disease, congenital valve abnormalities, including bicuspid aortic valve disease, cardiovascular implanted electronic devices, hypertrophic cardiomyopathy. Antibiotic prophylaxis is not routinely recommended for patients at intermediate risk of endocarditis but may be considered individually. However, prevention measures, such as avoiding contact with people who are sick, are strongly encouraged for these patients. The endocarditis team. The endocarditis team includes at least cardiologists, imaging experts, cardiovascular surgeons, infectious disease specialists, a microbiologist, and a specialist in outpatient paternal antibiotic treatment. Patients with uncomplicated infective endocarditis can be managed in a referring center with early and regular communication with a heart valve center endocarditis team. Patients with complicated infective endocarditis should be treated in a heart valve center with an endocarditis team and facilities for immediate surgery. Diagnosis. The diagnosis of infective endocarditis is based on a combination of major and minor criteria. It utilizes the presence of predisposing conditions, fever, blood cultures, evidence of embolic vascular dissemination and immunological phenomena, and imaging for valvular and paravalvular or periprosthetic anatomic or metabolic lesions using transthoracic (TTE) and transesophageal echocardiography (TEE), cardiac computed tomography angiography (CTA), 18-FFDG positron emission tomography (PET), and white blood cell (WBC), single photon emission tomography (SPECT), CORT. A transthoracic echocardiogram is recommended as the first-line imaging modality in suspected infective endocarditis. Transesophageal echocardiogram is recommended in patients with suspected infective endocarditis but negative transthoracic echocardiogram in patients with a prosthetic valve, and before switching from intravenous to oral antibiotics. Repeat transthoracic echocardiogram or transesophageal echocardiogram is recommended within 5 to 7 days if clinical suspicion for infective endocarditis remains high, the initial exam is negative or inconclusive, and as soon as a new complication of infective endocarditis is suspected. Cardiac CTA is recommended in patients with possible native valve infective endocarditis, or NVE, or prosthetic valve infective endocarditis, or PVE, to help confirm a diagnosis and to detect paravalvular or periprosthetic complications if echocardiography is inconclusive. 18-FFDG PET CORT is recommended in patients with possible prosthetic valve endocarditis and may be considered in patients with likely CIED-related infective endocarditis. WBC SPECT CORT should be considered in patients with suspected prosthetic valve endocarditis when echocardiography is negative or inconclusive and 18-FFDG PET CORT is unavailable. Brain and whole body imaging, CT, 18-FFDG PET, CT, and magnetic resonance imaging, is recommended in symptomatic patients with native or prosthetic valve endocarditis to detect peripheral lesions. It may be considered for screening for peripheral lesions in asymptomatic patients. The guidelines include algorithms for diagnosing native valve endocarditis, prosthetic valve endocarditis, and CIED-associated infective endocarditis. Antimicrobial therapy. Principles and methods. Antibiotic treatment for prosthetic valve endocarditis should be longer, more than 6 weeks, than for native valve endocarditis, 2 to 6 weeks. The first phase of antibiotic treatment consists of 2 weeks of in-hospital parenteral treatment, during which surgery should be performed if indicated, infected foreign bodies should be removed, and cardiac and extracardiac abscesses should be drained. In selected patients, a second phase of antibiotic treatment consists of outpatient oral or parenteral antibiotics for up to 6 weeks, about 1.5 months. As mentioned above, oral parenteral antibiotic therapy should start only after a transesophageal echocardiogram documents the absence of local progression and complications, including severe valve dysfunction. Specific recommendations for antibiotic therapy are made, including aminoglycosides are not recommended in Staphylococcus native valve endocarditis. Rifampin should be used only in infective endocarditis involving foreign material, including prosthetic valve endocarditis. Daptomycin should be administered at high doses, 10 mg per kilogram once daily. Indications for surgery. The 3 general indications for surgery in acute infective endocarditis are: 1. Congestive heart failure, 2. Uncontrolled infection, 3. Prevention of septic emboli. Emergency surgery, within 24 hours, is recommended when aortic or mitral native valve endocarditis or prosthetic valve endocarditis causes regurgitation, obstruction, or fistula, resulting in refractory pulmonary edema or cardiogenic shock. Urgent surgery, after 3 to 5 days, is recommended. 1. In aortic or mitral, native valve endocarditis or prosthetic valve endocarditis resulting in heart failure. 2. With evidence of locally uncontrolled infection, abscess, false aneurysm, fistula, enlarging vegetation, prosthetic device, new atrioventricular block. 3. With persistent vegetation of more than 10 mm after more than one embolic episode or vegetation of more than 10 mm and other indications for surgery. Urgent or non-urgent surgery, depending on patient hemodynamics, is recommended for fungal infective endocarditis or infective endocarditis caused by a multi-resistant organism. Surgery is recommended for early prosthetic valve endocarditis or prosthetic valve endocarditis within 6 months of valve surgery, with complete debridement and valve replacement. Complete system extraction without delay is recommended in patients with definite CIED-related infective endocarditis during initial empiric antibiotic therapy. Surgery for right-sided infective endocarditis is recommended. 1. In patients receiving appropriate antibiotic therapy who have acute severe tricuspid regurgitation resulting in right ventricular dysfunction. Recurrent pulmonary emboli requiring ventilatory support. 2. Large, more than 20 mm, residual tricuspid vegetations. 3. Involvement of left-sided structures. Tricuspid valve repair rather than replacement should be considered. Other complications of infective endocarditis. Other complications of infective endocarditis include neurological, infective, mycotic, aneurysms, splenic complications, like splenic infarction or abscess, myocarditis and pericarditis, conduction disturbances, musculoskeletal manifestations, and acute renal failure. Immediate epicardial pacemaker implantation should be considered in patients with 1. Valvular infective endocarditis undergoing surgery who have complete atrioventricular block, AVB, and one predictor of persistent AV block, or preoperative conduction abnormality. 2. Staphylococcus aureus infection. 3. Aortic root abscess. 4. Tricuspid valve involvement. 5. Previous valve surgery. Surgical therapy. Principles and methods. Preoperative coronary angiography, in the absence of aortic valve vegetation, or coronary CTA, in patients with aortic valve vegetation, are typically recommended for men more than 40 years old, postmenopausal women, or others with a history of coronary artery disease or more than one cardiac risk factor. Surgery should not be delayed in patients after a transient ischemic attack or documented non-hemorrhagic stroke in the setting of HF, uncontrolled infection, abscess, or persistent high embolic risk. Surgery delay, more than 4 weeks, should be considered in patients with significant preoperative hemorrhagic stroke. In patients with hemorrhagic stroke and unstable clinical status, HF, uncontrolled infection, high embolic risk, urgent or emergent surgery should be considered, weighing the likelihood of a meaningful neurological outcome. Outcome after discharge. In contrast to reinfection, which means infective endocarditis caused by a different organism, usually more than 6 months after the initial episode of infective endocarditis, relapse, that means infective endocarditis caused by the same organism, requires a search for a persistent infective focus and evaluation for possible surgical intervention. Blood cultures should be performed after the completion of antibiotic treatment. After completing treatment for infective endocarditis, patients should remain under close surveillance for long-term complications. Patient education is recommended for the risk of infective endocarditis recurrence and preventative measures emphasizing dental health. Addiction treatment is recommended following infective endocarditis in people who inject drugs. Patient-centered care. A recovery plan should be developed in collaboration with the patient in absent support networks or adverse social factors, highlighting information about future preventative measures and the risk of infective endocarditis recurrence. Sex differences. Female sex is less common in patients diagnosed with infective endocarditis, present in approximately 1/3 of cases. Overall, the new guidelines are based on the best available evidence, for example, the POET trial, which showed that partial oral antibiotic therapy is a safe and effective treatment option for patients with left-sided infective endocarditis. But many of the recommendations are based on expert opinion and/or observational data. More research is needed to confirm the benefits of some of the recommendations, such as oral antibiotics. The new guidelines provide clinicians with updated guidance on managing infective endocarditis. They are a valuable resource for improving the care of patients with this serious condition. This is the end of the summary of the European Society of Cardiology Guidelines on Infective Endocarditis Management in 2023.
Thank you for listening to this podcast, Why We Do What We Do in Cardiology. The information in this podcast is for general information only for medical professionals and is not intended to be a substitute for medical advice from a qualified healthcare professional. We hope you found this information helpful, and we look forward to seeing you on the next episode.